Good morning. Welcome to the second day of AVLS, and you are right now in the lymphedema session, Lymphedema in Practice. And what we're going to be speaking about this morning is complex lymphedema therapy. Dr. Steven Dean is going to start us off here. So Dr. Dean, thank you so much for speaking with us today. And the title of his talk is Lymphedema with CVI, the Incidence and Considerations. Take it away.
Thank you, Paul, for that kind introduction. And so we're going to start off with a couple of quick questions on Phlebolymphedema. Question number one, I'd ask you to identify the true statement. Is it cancer therapy is the dominant cause of lower extremity lymphedema in the U.S.? Foot swelling is required in order to diagnose Phlebolymphedema. Toe swelling is required in order to diagnose Phlebolymphedema. Or Phlebolymphedema predisposes patients to contact dermatitis. Quickly, what do you think the right answer is? Well, it is actually number 4. Phlebolymphedema predisposes patients to contact dermatitis. We'll review all of these topics in the ensuing lecture. And question number 2, which I think is fairly easy, identify the subject that has Phlebolymphedema. Would it be subject number 1, subject number 2, subject number 3, or subject number 4? And hopefully you chose the correct answer, which is number 2. This is classic Phlebolymphedema with a rather marked lipodermatous sclerosis with all the atrophy you see there. So all right, so that's just a good segue into the lecture here. And let's see here. All right. Okay, can you see things okay?
Looks good.
Okay, all right. So I've already heard about the topic of my presentation today is minimally relevant disclosure that you have to put. And really what I want to do is look at this lecture in the context of 4 reasons why you should care about the increasingly recognized topic of Phlebolymphedema. Number 1 would be that understanding its pathophysiology provides useful insight into updated concepts in lymphatic failure. Specifically, let's go back and then look at the time-honored Starling Principle of hemodynamics within the blood capillary. Now, recall all the way back in 1896 when Ernest Starling devised the Starling Principle. He stated that hydrostatic pressure drives filtration of fluid macromolecules from the precapillary arteriole into the interstitial space. And then because of the resultant oncotic pressure gradient, fluid, this accumulated fluid would actually be reabsorbed within the postcapillary venule. But unfortunately, back in 1896, Dr. Starling was not aware of the presence of the endothelial glycocalyx and that, in fact, it disrupts this oncotic pressure gradient within the postcapillary venule. Therefore, there really is no appreciable venous resorption of fluid within the venule. So all of this accumulated interstitial filtrate is absorbed via the lymphatics. So the lymphatics, not the venules, are primarily responsible for maintaining tissue fluid balance by absorbing the interstitial fluid and proteins and returning it to the circulation. So because of this, even Drs. Mortimer and Roxman, in this excellent article entitled New Developments of Clinical Aspects of Lymphatic Disease in 2014, they recognize, based on these updated principles, that all chronic edema indicates an inadequacy or failure of lymphatic drainage. And therefore, the edema that's associated with chronic venous insufficiency actually represents secondary lymphedema. And it's useful to look at this concept within the context of the CEAP or CEAP clinical classification of chronic venous disease. And it's important that you recognize that by the time you have a patient that has C3 disease with edema or greater with skin changes, by definition, these patients actually have chronic venous insufficiency, and therefore any associated secondary venous edema actually represents a venous lymphedema or Phlebolymphedema. Now, let's talk about the purest definition of what constitutes lymphedema and use that concept while examining these 4 limbs? Well, the purest definition would be the accumulation of protein-rich fluid in the interstitium, which causes chronic inflammation and reactive fibrosis of the affected tissues. So then that begets the question, when you have a patient that has C3 disease, as seen here, no significant fibroinflammatory changes that we can see, do they really have lymphedema, or is it simply lymphatic failure? And I think that's a valid point to discuss. But I don't think there should be any question by the time you have patients that have advanced skin changes of lipedema sclerosis, blanche, a stasis ulcer, that these patients actually have a chronically inflamed reactive fibrotic environment consistent with this purest definition of lymphedema. And then you get into further arguments by saying, well, that patient with lipedema sclerosis, I really don't see a lot of edema there, so how could you use the term Phlebolymphedema? I still would feel very comfortable using it in the sense that you can't tell me that their dermal lymphatics are normal and they don't have dermal fluid. It may not be clinically evident, but it's there. Their lymphatics are completely destroyed within the dermis. So reason number 2 that you should care, it is the most common cause of lower extremity lymphedema in Western countries in the United States, even though so many articles continue to state the following. I mean, here is a 2020 ostensibly up-to-date reference that states the following. In the developed world, the majority of cases of lymphedema are secondary and due to malignancy or its treatment. But I just don't believe this is real life data. And unfortunately, there really is no great data on the exact prevalence of Phlebolymphedema in the United States. However, I think we can extrapolate and construct some useful numbers based on the following. Here is a statement from the European Society of Vascular Surgery in 2015, recognizing that CVI, by definition, C3 to C6 disease, affects about 5% of the population. So if you assume there's 325 million people in the United States, at least 16 million of them should have secondary lymphedema from chronic venous insufficiency. And you contrast that with numbers, I've heard Dr. Roxon speak on that, the cancer-associated lymphedema probably runs in the 1.5 to 2 million range. And then also, there is a relatively new data. I mean, obviously new. Here's a 2013 reference showing that CVI and not cancer was the most common cause of lower extremity lymphedema in some of these series. And it was 34% in a Mulick study. In the Canadian registry published last year, it was 72%. And then finally, data from our institution that just published this year, it was 42%. And that 42%, I think, is somewhat of a skewed number because there was inherent referral bias in our study because it was completed at a cancer-affiliated lymphedema center. If it wouldn't have been cancer, I bet that number would have been much, much higher. So the most common cause of lower extremity lymphedema, despite this statement that we read time and time again that it's cancer, I don't think that's real life. I think that the scales are clearly weighted in favor of Phlebolymphedema, not cancer being the dominant cause of lower extremity, secondary, or even primary lymphedema in the United States. I'll just say the most common cause of lymphedema in the United States. It's probably at least 6, if not 8 times more common than cancer-associated lymphedema. Third reason you should care, it's associated with characteristic and rather diagnostic clinical manifestations, such as seen here. If you had any limbs like this in your office, I would just think that's all these are textbook representations of Phlebolymphedema. We have leg swelling, we have a modest amount of foot swelling, we have stasis hyperpigmentation, we have some lipedema sclerosis. These patients have obvious Phlebolymphedema. And all of these, by the way, clearly would have a reactive fibrotic environment. Why you would feel the need to get a lymphoscintigraphy on these patients to confirm the diagnosis, I'm not sure, but sometimes it's done. And it's really important that you recognize that foot and toe swelling is not required to make a diagnosis of lower extremity lymphedema. You don't have to have foot and toe swelling. And here's a perfect example. If you were to, you want to get a lymphoscintigraphy on a patient, well, you get it on this patient, you'd find significant dermal backflow with these within these inflammatory changes of the mid and distal calf. Clearly that patient has Phlebolymphedema. And the last reason you should care, number 4, it's associated with very characteristic clinical ramifications. And these ramifications, I think, are useful to address in the context of this article, Phlebolymphedema, a disregarded cause of an immunocompromised district. Wonderful reference by Drs. Ruocco and Associates. I encourage you to pick it up. and read it. And here are some examples of immunity-related disorders that can appear on a Phlebolymphedema district. I think most of us would recognize the associated reduced immune response that predisposes one to opportunistic infections such as cellulitis. And so, of course, here's some classic examples of cellulitis in the setting of Phlebolymphedema. So again, I suspect most people know that, but don't forget that this also underlies this predisposition that lymphedema and Phlebolymphedema patients have to recurrent and recalcitrant fungal infections. So this is not an uncommon scenario. If you take the time to look between your patient's toes, you'll find these horrible cases of tinea pedis that prove recalcitrant to therapy. And it's interesting, I was always taught that this is probably occurring because they have swollen toes. It's a moist environment, therefore predisposing one to a fungal infection, which intuitively that makes sense. But when you realize you also have to account for this local reduced immune response, that's probably playing an equally important role in why these cases of tinea pedis can become so recalcitrant to therapy. And then also onychomycosis is very common in the lymphedema and Phlebolymphedema population. Also, this reduced immune response predisposes one to recurrent local malignancies such as carcinoma. I mean, here is a great example. I mean, you couldn't find a better example of Phlebolymphedema, disregarded cause of immunocompromised district. I mean, this patient has Phlebolymphedema, right? You can see the stasis hyperpigmentation. Look at all the venulactasia, small varicosities. Here's an ulceration, but there's this unusual appearance to this. Previously, this was a stasis ulceration, but now it's converted into a squamous cell carcinoma. Look at that proliferative, friable base suggestive of squamous cell carcinoma. And then finally, don't ever forget this entity. If you ever see purplish plaques and nodules that fail to resolve in the setting of a lymphodematous limb, this is deadly lymphangiosarcoma with a mean survival of about 20 months. But all of these malignancies are occurring in the setting of an immunocompromised district. And then last of all, the clinical example I find the most fascinating is this paradoxical, exaggerated immune response that predisposes one to developing allergic contact dermatitis. How many times have you seen a patient like this? They've got a dried eczematous stasis dermatitis. They apply a little over-the-counter eczema relief cream on the affected skin, and look what happens. You transform it into an acute weeping eczematous dermatitis, and that's occurring because of this paradoxical, exaggerated immune response that triggers a topical hypersensitivity and allergic contact dermatitis. And so a lot of times people say, well, you just need to get a steroid cream, a prescription steroid cream, and that will take care of the problem. Well, the problem is it will happen with a lot of different steroid creams. So again, this is all occurring because of this Phlebolymphedema district. By the way, ointments are less sensitizing than creams and lotions. That's something to keep in mind when you do treat these patients. So finally, let's wrap it up on why you should care about Phlebolymphedema. Number one, understanding its pathophysiology provides insight into updated concepts in lymphatic failure. And that specifically is that all fluid accumulation or edema represents some form of lymphatic failure. Again, we can argue on whether or not it represents lymphedema, but it's clearly lymphatic failure. It is the most common cause of lower extremity lymphedema in Western countries. I don't think there's any doubt about that. We just need more data to prove it. It's associated with characteristic and diagnostic clinical manifestations. Don't forget, you don't need foot and toe swelling to make a diagnosis of Phlebolymphedema. And we just reviewed its associated characteristic clinical ramifications. Again, don't forget about this predisposition to local malignancies, as well as topical hypersensitivity with allergic contact dermatitis. So I will stop there and share my screen and give this to the good doctor a day.